I'm an academic radiologist, so one day a week on a Tuesday, I go down to the X-ray department and make like I'm a doctor. I actually do some ultrasound scans and see patients and interact with them. But the other 4 days of the week, I'm up in the department doing academics, doing research, and not with patients. So this talk is going to have a much more academic bent. And as an academic, I have to start by saying that I have no conflicts of interest to disclose. When we image, I'm a pediatric radiologist. Most of this talk is going to be around pediatrics, imaging children rather than adults. We're trying to make the diagnosis by looking at bone shape, by looking at bone modeling. So for example, I can tell that this child has osteogenesis imperfecta type 5 because the elbow is dislocated and because there is a curious sort of pattern here of the ulna. So that's osteogenesis imperfecta type 5. This child has multiple healing rib fractures and broad ribs, and I would then sort of speculate it was type 3 osteogenesis imperfecta, and this is an infant with type 5 OI simply because of the appearance of the ends of the long bones of the thigh. We also image, we can look at bone density, and reduced bone density helps us to confirm, not necessarily to make the diagnosis, but to confirm that there is reduction in bone density and perhaps initiate pimidinate treatment. And we also image to look for complications of the OI itself and maybe of treatment. This is a child that's got tightening of the base of the spine and it's compressing the cord because of the softening that happens at the skull base. Today, I'm going to be talking mainly about the research that we do around making the diagnosis, looking at bone shape modeling and bone density. The other thing in the title of this talk was, when I was asked to give, was what is new? Well, what does new mean? How new is new? Really, the sort of thing we talk about when we talk about news, we want to be wowed, we want to go, ooh, really interesting, revolutionary, whereas actually, in fact, imaging, medicine as a whole, is a sort of evolutionary thing. It's a step-by-step process. We work on research that others have done and to build up. And really, that's what I'm going to be talking about today. The research that we've done predominantly in Sheffield that brings, it is new, but it's not sort of revolution. It's not really fantastic. And so there are three sort of categories. What is relatively new, but should be implemented now if it's not being. What is relatively new but could be widely implemented very soon. By soon I mean sort of 5 to 10 years. And what is truly novel, hopefully will succeed and be implemented again pretty soon, 5 to 10 years. So the first thing we'll look at is vertebral fracture assessment. It's not new in adults, but it certainly is new to the pediatric world. Ordinarily, we diagnose vertebral fractures by looking at the spine radiographs. It's very rare that a child will come in with a mild vertebral fracture as a symptomatic presentation with back pain. It's important to pick them up because otherwise they progress and it can lead to finally relatively significant deformity if not treated. And the traditional ways we do an X-ray of the spine, we call that a radiograph. Of the lateral spine. If you look at the front of the spine, we can diagnose the curvatures, and if we look at the lateral spine, this loss of height, all of these are flattened. They should be nice and rectangular, perhaps more, all of them, and we can see that they are all flattened, multiple levels. This is a milder case. I just blow that up, this area, and you can see that there is some loss of height here. So these severe fractures, we can pick them up and agree amongst all ourselves that the fracture is there. It's not called a fracture until there's loss of 20% or 25% height, depending on which author, which researcher you look at. But that means that until it's lost height of 20% or 25%, it may still be a fracture. It's just that we're not calling it a fracture. Although there's that limitation, these spine radiographs are what we do routinely. It's been the standard, and children with OI will have an annual chest spine radiograph, lateral spine, in addition to their DEXAs. And this is a very high radiation dose. And compared to adults, children are much more likely to get radiation-induced cancer. Number one, because they've got smaller bodies, and so the effect on their smaller bodies. And number two, because they've got many more years in which that cancer has time to develop. So we really do want to try and reduce radiation dose. DEXA, as you're all aware of, traditionally measures bone density. And I've shown you this image before, and we can see that this child has a reduced bone density, falling far below the lower limit, 5% of the population line. But now, with new machines, this is the quality of the lateral DEXA images that we're getting. Because we can swivel the tube round and do a lateral DEXA. And when you're looking for fractures from a lateral DEXA, that's what is called vertebral fracture assessment, VFA. And it's pretty common now in the adult world. But what we wanted to ask was, can DEXA replace conventional radiographs, conventional X-rays for vertebral fracture diagnosis in children? So how reliable is VFA in children compared to X-rays? And so we did this diagnostic accuracy study, inter and intra-observer reliability. Everything in radiology needs somebody to observe the radiographs or the ultrasound or the CT scan, and that person, usually a radiologist, is called an observer. Inter-observer means how does radiologist 1 compare to radiologist 2? Do they agree? And intra-observer reliability means how does radiologist 1 compare to radiologist 1 next week, or in 2 weeks' time, or in 3 weeks' time. And ideally, it shouldn't be subjective. All radiologists should agree with each other, and I should always agree with myself, whether it's a Monday or a Friday, whether it's winter or summer. And so that's what inter and intra-observer reliability is about. We also wanted to look at image quality, wanted to look at radiation dose savings, because we know that DEXA has a lower radiation dose than radiographs, and we want to look at the patient and carer experience. So we recruited 250 children between 2011 and 2014, children so up to the age of 15 years and 364 days. And we had 66 DEXA and radiograph pairs that were contributed to us by Birmingham, for which we're very grateful. 3 consultant pediatric radiologists, so 3 different observers, and we looked at all the 250 X-rays and 250 DEXAs independent of each other and at different times and in random order. Then we did a second read of 100 X-rays and 100 DEXAs, again independent, without changing the numbers, so we didn't know what we'd said the first time. So that allowed us to compare between the radiologists and within the radiologists. And then the final read was of 3 together. The 3 radiologists looked at all the 250 X-rays. This was our reference standard, and in radiology it's often difficult. You can't look under a microscope or do something that will tell you for definite that this is a fracture. So what we used as our reference was the agreed report of all the 250 radiologists. The children had an average age of about 11 and a half years. Just under half were male and just over half were Caucasian. And this is one child's VFA and X-ray, and we can see multiple level fractures. This is another child, more subtle fractures with loss of height of about 24% at T11. And by serendipity, really, we found out that DEXA sees the vertebral bodies better in the upper spine than X-ray, and also far better when there's rodding in situ. So that's really an important finding, because many of our children will have these rods. Of course, when it's very severe disease with big curvatures, both DEXA and radiographs were not very good at showing the images. And this is a fairly complicated table. If you really want to read the whole paper, you can get it here. The thing I really want to show you is that the diagnostic accuracy, the observer reliability, the discomfort, the image quality was more or less similar for both DEXA and radiographs. But if you notice that there's 1/5 of the radiation dose saving for DEXA compared to radiographs. And for a child who's having radiographs minimum once a year from the age of 1 or 2 upwards until the age of 16, that is a significant radiation dose saving. So really, these DEXA machines are widely available now, and there's no reason why any of our children should be having spine radiographs routinely and consistently when they can be having DEXA VFA. The other thing that's relatively new that can be implemented now is the EOS imaging system. This is a pretty clever piece of kit that takes the images from the front and from the side at the same time. And it can be done while the patient is standing or sitting in a chair rather than lying down. So you actually get the true weight-bearing properties and alignment of the lower limbs, the upper limbs, the spine. And it gives you 3D surface radiographs. So the radiation dose is comparable to DEXA. And this is the quality of the images that you can get. And we can measure scoliosis, which is curvature of the spine. We can look at bowing of the limbs. And also you can detect the fractures as you would with standard radiographs. There is already a machine at Alder Hey, I think, and Catherine will confirm, that GOS is getting one and will be installed, and we will be having one in Sheffield, hopefully installed by the end of 2017 and this year, and that's courtesy of funding from the Children's Hospital charity. I wasn't actually sure if I was allowed to say who the well-known retailer is, so I sort of erred on the side of caution. But we've got money to have it. So really, by this time next year, you or your children may be having imaging with the EOS system at Sheffield. It will be accessible to both children and adults. So what's relatively new, may be widely implemented soon, would be a quantitative morphometric vertebral analysis, MXA. Essentially, this is reading the DEXA VFA, we've just been speaking about VFA, but using software. So the inter and intra-observer reliability, although I said, and it sounded as if it made DEXA a good thing, was equal to radiographs, they're both actually very poor. So we really, we need something that allows us to more consistently agree with each other whether or not there is a mild fracture. With the severe fractures, there was excellent agreement. Everybody would agree that there was a fracture when there was a height loss of 50 or 60 or 70%. But the milder fractures are the thing that there's a problem with. And so there are software tools, and Spine Analyzer by Optasia Medical Limited is a fairly common one used in adults. And in adults, it gives excellent inter and intra-observer reliability. And so you would imagine that that would be the case also for children. We were fortunate enough to get some funding from the University of Sheffield to assess Spine Analyzer on children's radiographs. And what you do is you tell the system where the vertebral bodies are by marking the center of each vertebral body, and then you press the button and it very cleverly gives you the 6 points around each vertebral body and does the height ratios for you. It's not perfect, so sometimes you need to change the actual position of some of the points, but it is very good, and it tells you if it's a mild fracture. If it's moderate, it would be an orange square, and if it's severe fracture, it would be a red square. And the maximum time it takes per child is about 5 minutes. So that's fantastic, and because it's the machine doing it, you would expect that each observer would put the points in the same place, identify the vertebral bodies, that inter and intra-observer reliability would be very good. You can also, if there are rods and you can't see the vertebral bodies, you can skip out the vertebral bodies. So it's very versatile. And we had 5 observers, looked at 137 of those 250 X-rays, and so that gave us a total of 1,781 vertebrae, of which just under 1,200 were well seen by 3 or more observers. And we were expecting that we'd have very good inter and intra-observer reliability. So the good news is that the specificity was 97%. This means that when there was no fracture, 97% of the time the software agreed that there was no fracture. And it sort of went rapidly downhill from there. Sensitivity was 18%, which means that when there is a fracture, as the 3 radiologists were feeling that there was a fracture, the software only agreed 18% of the time, which is not good. 8 out of every 10 fractures was being missed by this software tool. Inter-observer reliability was poor, around about 0.5%, and intra-observer reliability was better, but also very poor. They were both, in fact, worse than what we were using when we're just eyeballing it, as it were. Now, why might that be? First of all, the software is based on adult data. The Ganant score that it uses was created by looking at the vertebral bodies of 57 postmenopausal women. Secondly is that there is this adjustment of the points that we sometimes have to do. And thirdly is that the software is only as clever as us. We don't know what is normal in children, so we can't tell the software what is normal in children. Now here are some examples. These 2 vertebral bodies, 11 and 12, that we as the radiologists were sure, and we agreed amongst ourselves that there were fractures. And the software called them normal, probably because of this 25 or 20% cutoff, which it's sort of sticking to very rigidly. The software doesn't sort of allow for 18% or 15%. Secondly, in terms of placement of points, and I'm sorry that this is very blurred, what it's saying here is the level, so that's T10, T11, T12, and then it's talking about the type of fracture, wedge, concave or crush, and the grade of the fracture. And this is T11 in red with the red dots that I'm highlighting here, and there was no fracture. This is the same image, and we've just moved the red dot at the front top corner, and now it has got a fracture. And if I put them side by side and draw this line for you, if you look at the top line, we've really only moved this red dot down by about 1 millimeter. And that 1 millimeter move is the difference between there being a fracture or not a fracture. And so this would account for that high inter and intra-observer reliability. And then finally, there's normal wedging of the vertebral bodies at T7, T8 in everybody, children and adults. And the software thought it was a fracture, a severe fracture for T7 and a mild fracture for T8, which we had thought was just normal physiological wedging. It does raise the issue of how much wedging is physiological, because the software could be right. We're just saying, so we don't actually really know. So the paper is about to be published, but the important thing is that we really do not have a normal baseline for diagnosing vertebral fractures in children, and that's an important step that needs to take place. We've calculated we would need to recruit about 1,400 healthy children and young people into such a study to cover all the various age groups, the different ethnicities and the sexes, and we're hoping to get funding to be able to do this. For the time being, MXA is out, and we're doing VFA, but using observers, just looking at the images, eyeballing the images and deciding if there's a fracture or not. And then moving on to what is relatively new, could be widely implemented soon, HRPQCT. Some of you may already have had HRPQCT, high resolution peripheral computed tomography. It uses a CT scanner, but it's a much smaller CT scanner, and the resolution is amazing, 82 microns. It can give you 3D images, and it looks at the difference between the cortical bone, which is the outer bone, the shell of the bone, and trabecular bone, which is the more spongy bone, where the bone marrow is. And we can use the images to do biomechanical tests. The engineers do some biomechanical tests. Of course, nothing is ever perfect, and the thing is, it can only take the end 8 millimeters of your wrist bones or of your ankles, and that end 8 millimeters is what we use to infer what the entire skeleton is like. So it hasn't actually been used very much in children, and certainly not in children with severe OI. Maria Digby, one of our students, was involved in this study where we were looking at the ease of positioning and scanning children with OI with HRPQCT and using it to assess the bone parameters. It's not straightforward because the machine is at the Great Northern General Hospital, which is some distance away from Sheffield Children's Hospital, and so transportation and things had to be arranged in between them receiving their permidronate while they were on the ward. So it's quite difficult, the logistics of it, but we did manage to do HRPQCT of both wrists and both ankles, and they had a whole body DEXA, and they were patient enough to respond to a questionnaire for us to document their experiences. And this data was compared to normative data that Paul Dimitri in our hospital had already done by looking at a study comparing lean children with obese children. We've only managed to recruit 9 children so far, and we've looked at a control group of 9 children as well. And the Z-score, it was normal because most of them had been or were on bisphosphonate therapy. And nevertheless, you can look at the fracture history to see what our group had a total of 30 fractures, whereas the matched control group had no fractures at all, which is to be expected. You need to position them pretty carefully because we don't want to cause a fracture, and also they have to keep still for about 3 minutes, which, well, children, 3 minutes is forever, really. So very difficult, but with the padding, we did manage to succeed most of the time. This little girl couldn't sit on the chair with the extension, so she's on the side of the chair with the pillow behind the arm and got her leg in, but we were successful. We only failed for 3 ankles out of all 36, so that was pretty good. And we asked them, there was no real preference for CT or for DEXA, and the bone mineral content was, although the DEXA BMD, bone mineral density from DEXA, was within normal limits, we could actually see that there was a difference in bone mineral content in the OI group compared to the control group. There was a significant difference in cortical strength, and in trabecular strength in these groups, and there was increased inhomogeneity, so the alignment of the trabecular bone was abnormal in the OI group. So there were parameters that HRPQCT was giving us more sensitively and more information that we can get from DEXA scans. And this is the sort of images that you can get. So they look as if they're microscopic, histopathological. And if you've seen the radiographs of children on bisphosphonates, you'll have seen those bisphosphonate lines. And that's what these are here, the bisphosphonate lines. And so you can actually measure things like the trabecular thickness, the size of the gaps between the trabeculae. It's very good, just for a 3-minute scan. And these are the ankles of some of those children as well. The main reason there were limitations to our study was the small sample size and the variation in OI type. And of course, you can't use it if the children have got intramedullary rods. The 3-minute scan time is another thing that once they shake and once there's some movement, you probably have to repeat the scan again. And there were only 4 machines in the UK, which is why I say perhaps it will be implemented, although it's looking reasonable, it's not something that will be implemented widely in the next 5 years, maybe 10, 15 years' time. It's a fairly expensive piece of kit, and the normative data for children is going to be very difficult to develop because they grow. And you're only looking at the last 8 millimeters. By the time you get them back in 3 months or 6 months, you're not looking at the same 8 millimeter distance. And so it's going to be difficult to decide whether there's an improvement or whether it's how to compare the last scan result to the current scan result. And that's work that will be ongoing. And then finally, in the last few minutes, what is truly novel, but will hopefully be implemented soon, we're doing some work with vibration density analysis. So far we've been talking about looking at the bone strength. Now if we're looking at just the bone density alone, DEXA is the current standard, the gold standard. But it does look at areal rather than volume, so looking at a 2D structure instead of the 3 dimensions of the bone. And we have no validated data for children below 5. It's lower radiation than X-ray, but it still is radiation. And most importantly, it doesn't actually predict fracture risk. And we're trying to develop things that maybe will address more of these issues. In industry, vibration is used to assess the density of structures and also to look for cracks in great big machinery that they don't want to take down. To look for the cracks, you can just vibrate and it will tell you if there's a crack or not. So it works on the basis that if you take 2 cylinders, for example, of the same material, the same size and width, and you vibrate them along, they'll give you a trace. And that trace will be identical anywhere along that cylinder, as long as it's the same material. But the moment you change the material, or if it's a hollow cylinder, you fill it with fluid or oil or something. So it's also used in shipping to detect smuggling. And you do that vibration, you get a different trace, both in terms of the shape and in the size of the vibration that you might get. So we thought, well, perhaps this can be used to look at fractures, and also, in the context of today's talk, to look at bone density. So we started because the advantages we felt would be the lack of ionizing radiation. It's non-invasive, it would be relatively cheap, rapid, and we could use it in children under 5. We began with looking at various blocks of wood, beech, ash, oak, etc., of known density, and we were able to detect, we could tell which piece of wood it was by looking at the tracing of the vibrations, and then different sponges of different density, and turkey legs without the skin and the muscle and the bone. So that was Helga's PhD study, and ultimately, with funding from the Children's Charity, we were able to look at 41 children. We'd begun on the turkey legs and things with just a marble on a piece of string, and we progressed to this instrument, and that gave us this result of correlation between vibration and DEXA of 86%, which was encouraging, and got a further funding to extend this to younger children, so down to the age of 7, to try and recruit up to 100 children and to improve the look of the device, which was always a bit, for the younger children, it looked more frightening. And this is what we've got at the moment. So there's a spring here, there's a solenoid that picks up the vibration, and this is the tapper. that taps, when you press the button, it taps the bone. We tap at the elbow, avoiding the funny bone, and we pick up the vibration along the bone at the wrist, at the prominent bit of the bone at the wrist. And we've recruited 61 more children between February and July this year. So far we've fully analysed the data on 19, and this is a complicated table, but really just look at the bottom right. This t-test, a number of this high tells you that there's no difference in the values that we're getting between DEXA and vibration. So that's encouraging. And you might think if we're tapping the bones of children, and certainly this is what the ethics committee thought, the children would go, ow! But in fact, they don't. They found most children preferred the vibration analysis. The problem when you're doing this sort of study is by the time they've read the information sheet, they know what you're trying to do. I think that people are trying to be kind to you and trying to give you the sort of answer that you want. So they've all said they prefer vibration, all except this patient that said there was no difference, and he's the youngest patient so far, and we know that children don't really care at that age. So I think we've got to sort of look at this result with a pinch of salt. It's probably that there is no difference. Most of them are trying to be helpful and kind. So we are actually looking for further funding to develop and commercialize this system. So just to summarize then, VFA should be used now. If you go and you ask them in your hospitals, have you got the modern DEXA machine? Can we have VFA instead of a radiograph? The EOS can be used now if your trust has got the money to purchase one. If you're coming to Sheffield Children's Hospital in the next year or so, you may actually experience the use of an EOS. HRPQCT and MXA may be used in the medium term, but we need to develop normative data. And as for vibration analysis, my children are sitting over there. They will know that I don't encourage idleness, but in this instance, I'd just say watch this space. Thank you very much. And these are the various individuals that I need to thank.